just the speaker view or everyone that's participating?
Well, that you can see it as per your convenience. I think Zoom allows you to change it as per your preference.
Yeah, okay. I thought in terms of your recording, it might also make
No, I'm
sense
not
to.
recording it. The IT team
Oh,
is. And let me now begin by uh, offering endearments to everyone who's turned in for this lecture on a Saturday evening. We're so honored and delighted to be in the presence of a leading scholar in the global health sphere and also other spheres of international law. Good evening to others as well. My name is Ankit Malhotra. I'm the co-founder and president of the Jindal Society of International Law, which is a student-led initiative under the aegis of Center for the Study of United Nations under the watchful guidance of Professor Dr. Weston Popowski. This society was founded in 2020 and is an initiative which is aimed to provide a platform to young international law enthusiasts. The 18th day of November 2020, the Herbert and Robin Roos Professor of International Law, Professor Jose Enrique Alvarez of NYU, along with our faculty coordinator, Professor Dr. Weston Popowski, and the Vice Chancellor of the university, Professor Dr. C. Rajkumar, and a dear friend of the Society and Center, Professor Dr. Mohan Kumar, launched this initiative of ours. The spring lecture series of 2022, entitled The Colloquium on Challenges to Global Governance and Humanities in the 21st Century, offers a compendium of scholarship from the academy and professional experience from the bar. Over the past year, the Jindal Society of International Law has hosted 100 renowned scholars and practitioners from the International Law Commission, international law firms, United Nations Institute of International Law, World Bank, and the Hague Academy of International Law. Through our previous series, we endeavored to study the contours of international law through speakers who covered and addressed their respective areas of expertise based upon their years of research and practice. Given the vast ecosystem and the engagement of international law in it, the Society aimed to study these disciplines in the ecosystems of public and private international law. Over the years, the Society has become a quorum of thought provoking discussions due to the engagement with experts exploring this ecosystem of international law. Thus, as a result, through the spring lecture series, it is important to understand the law and its challenges from broader, different, and differing vantage points. Acknowledging international law as a creation of states, it is also important to understand and appreciate the social sciences and the humanities that have played a key role in shaping international law. Thus, a broader study becomes crucial and also critical. Through this series, it is also hoped that one will develop a deeper understanding of Philip Jesup's magnum opus, A Modern Law of Nations, an introduction. He said, and I quote him here, so long as the international community is composed of states, it is only through an exercise of their will, as expressed through the treaty or agreement, or as laid down by an international authority, deriving its power from states, that a rule of law becomes binding. End quote. And to speak more about the future of international organizations and the future of global health, we today amongst us have Dr. Ayelet Berman, who is lead of the Global Health Law and Governance Program at the National University of Singapore Center for International Law, and is an adjunct assistant professor at the Faculty of Law. At CIL, she is also a member of the Investment Law and Policy Group. She is also the co-chair at the American Society of International Law and International Organizations Interest Group. Before joining the academy, she also practiced law, including WTO litigation at Sidley. She's also authored two books, which are coming in 2022: Rethinking Participation in Global Governance Challenges and Reforms in Financial and Health Institutions, and Investment Treaties and the Rule of Promise, the Asian Experience. With those words, I now invite Professor Berman to share her expert views on the topic, following which we will open the floor for questions and discussions. Professor, the floor is now yours.
Hi, Ankit. Can you hear me?
Yes, loud and
Can
clear.
you hear me? Okay, great, fantastic. I'm sorry, I had some technical problems. You'd think after so long in this pandemic, we'd all be masters of Zoom by now, but as it happens, I had some technical problems. So first of all, I really want to thank you personally and the Jindal Society for International Law more generally for inviting me, for giving this talk today on this topical issue of global health law, which finally, after so many years, is getting the attention it deserves thanks to this virus of COVID-19. So what I'd like to do is share my PowerPoint presentation. Let me just get that online. It'll take me a tiny moment and I'll share it with you. Okay. Okay, can you all see this now, my slides?
Yes, yes.
Is it very clear? Okay, fantastic. So the name of the presentation today, as has been invited by you, is International Organizations and the Future of Global Health Law. And essentially what I want to do today in terms of the plan I have is to first of all kind of give a very super short introduction about international organizations and the shift to global governance. Then I want to talk about how global health governance fits into this more general pattern of global governance that we see today. After that, I want to move on and focus on the World Health Organization, which still remains the most important international organization dealing with public health in the international sphere. And after giving this kind of general background information about the global health governance and law, what I want to do is kind of look at COVID-19 and the main challenges it has revealed in terms of our global health infrastructure. And when I say infrastructure, I kind of mean global health law and governance. We'll look at two main instruments in this context. We'll look at the international health regulations, which essentially manage pandemics, you could say, and at the TRIPS agreements, which manages intellectual property rights under WTO rules. And we'll see kind of the main problems that have come to bear following COVID-19. And then finally, what I want to do is kind of look at the recent proposal for a pandemic treaty, which tries to address some of the problems which have come up. And in that sense, thinking about the future of global health law, how it might change in the future, given these kind of proposals for a pandemic treaty. So I begin with a very, very short history of international organizations. So the first international organizations were kind of set up in the 19th century in Europe. They were mostly concerned with matters, again, with cooperation. It's always about cooperation between states, matters they need to cooperate on. At that time, it was mostly issues like the post or transport. And so there are a few international organizations then at the time. Especially we see it, and then especially in the period between World War I and World War II, then we see the establishment of the League of Nations, which, as we know, failed in preventing World War II. So there was a collapse there. But after World War II and the victory of the West, of democratic countries, we actually see the establishment of the United Nations, and with that, mushrooming over the years of many intergovernmental organizations. Now we have thousands of international organizations in a whole broad set of fields, from trade to finance, environment, and so forth, health, of course. So many international organizations sitting in Geneva, sitting in New York, and so forth. After the end of the Cold War, we also see a mushrooming of what I will be calling global governance. So that is other kinds of international collaboration, but that don't really fit these traditional intergovernmental organizations, these formal intergovernmental organizations like the UN. And that brings me to the next slide. So what we really see in the past, I'd say 30 years, since around the 1990s, is that we have kind of a shift from what was used to be referred to as international or intergovernmental organization to what we like to refer today more as global governance. So again, in the beginning, after World War II, we see the rise of intergovernmental organizations. What are they in essence, these organizations? They're organizations made up of member states, so sovereign member states, which agree on the basis of a binding legal treaty to come together and cooperate on a certain manner. Most often when they issue rules, these are binding rules, so treaties. But with global governance in the past 30 years, we see a lot of changes along these different categories. So we see a rise of many other actors beyond nation states in the international realm. Many non-state actors, if you will, civil society organizations, industry associations, foundations, and so forth. They've become very active at the international level. In the same manner, we also see new kinds of international collaborations that don't necessarily fall kind of within this treaty-based international organization. So all kinds of networks or partnerships, which I'll talk about shortly, that bring different actors together, often public and private, but they're really not treaty-based. And in that sense, from a legal perspective, they're essentially informal because they don't really have legal personality. That doesn't mean they're not important for international relations. They are still very important and often have quite significant effects and impact. But from kind of a legal standpoint, they're not based on legally binding treaties. And what we also see is that we see a huge shift if we look at the legal rules. So if we think traditionally about, the sources of international law, we think about customary international law, we think about treaties. What we see in the past 30 years is that many organizations are issuing a huge amount of normative documents that are not treaties. You'll find so many different names out there: guidelines, standards, recommendations, code of conduct, and so forth. These are all essentially normative documents that very often have quite significant effects on the actors or on diverse stakeholders, but they are not actually legally binding. So this is what, again, really in a nutshell, we could have a whole course on this, but this isn't the main topic for our talk today. So just in a nutshell, I think if we talk about international organizations today, it's more proper to talk about kind of global governance more broadly, because that's how international relations is taking place between these different actors in different kinds of formal and informal institutions. And also in terms of the rules, we're not only talking about treaties, but a whole kind of other kind of instruments of different normative levels. Which brings me to the next slide, which is how does global health fit into all of that? So if we look just, again, global governance, when you talk about global governance, we're talking about, so many different fields. There isn't any field of human activity, I think, in the world today that isn't in some way governed by global institutions, from trade to finance, environment, and so forth. So if we look at health specifically, we'll see that it's very much characterized by what I just said. So it really started out being mostly governed by the World Bank, the World Health Organization, and then the World Bank came in. And over a while, again, since around the 1990s, we see a rise of many new actors, non-state actors, especially. Think of civil society organizations like Oxfam or pharmaceutical industry associations, and so forth. So all of these actors have become really part of the global health infrastructure. And I'll talk about that a little bit more shortly, but this is just to kind of give you the sense that if we talk about global health governance these days, we need to think quite broadly in terms of the institutions, the actors, and the kind of norms that we'll be looking at, and can't be in a very kind of traditional public international law mindset, because that would really miss what is actually happening in global health governance. So in terms of the phases of development of global health governance, so as I mentioned before, in the beginning, the World Health Organization was set up, and that was really the main kind of international organization in charge of coordinating public health among countries in the world. The Then we have the World Bank, which also became a significant actor in the 1980s. And towards the 1990s, really, we see this rise of multiple stakeholders, a lot of multi-stakeholder partnerships. And these have all continued being very active. It's not that one has been replaced by the other, but they're all still very active, all of these different organizations in the field. So what I thought about that I would do first is try to look really at the World Health Organization, which has been a lot in the news recently, also for people that aren't global health scholars. So everyone knows, I guess, does anyone have not heard about the World Health Organization in the world? I doubt it. But so what I want to do first is really kind of let's look at some of the main characteristics of the World Health Organization, and just understand it, at its base a little bit better. So, as I mentioned before, it was set up following World War II as the United Nations Agency for Health. The constitution of the World Health Organization, again, essentially its binding treaty, the one that binding treaty of the member states, was signed in 1946 and then came into force in 1948. And in that year was also the first time that the World Health Assembly came together, which is essentially the assembly where all member states get together. Sorry. So what does the WHO Constitution actually tell us about the WHO? Sorry. So first of all, in terms of its mission, the mission of the WHO is the attainment by all people of the highest possible level of health. But look at how it defines health. Health is defined in a very broad manner. It's really not only focused on physical disease, but it defines health as a state of complete physical, mental, and social well-being, and not merely the absence of diseases or infirmity. So it really takes a broad approach, encompassing approach to health. What is expected of the WHO? The WHO should act as a directing and coordinating authority on international health work. So it's really considered kind of the main organization that's supposed to direct and coordinate among all member states the work on public health. In terms of its normative powers, which is what we're all always interested in terms of law as lawyers, the Constitution gives the WHO normative powers. It essentially says that the World Health Assembly is authorized to adopt conventions, agreements, and regulations, and make recommendations with respect to international health matters. So shortly, we look at these specific provisions, but essentially the WHO is in the Constitution considered as a coordinating and directing body, but also a body which has actually normative powers. And that's something to keep in mind, especially if we think later on when we talk about what has actually been done with respect to COVID and about reforms going forward. So in terms of membership and its organs, it has 194 member states. So it's de facto a universal organization. Most, if not all, countries in the world are members, and as such are bound by its constitution and also by its laws. In terms of the main governing bodies, we have the World Health Assembly, which I mentioned, which is kind of the main parliament, if you will, of the World Health Organization. Then you have the executive board, which is a smaller body with 34 members, which kind of implements the policies that the World Health Assembly decides on. Then it has a secretariat, which is essentially the technical and administrative arm. But as you've seen now with COVID, I don't think there is one person who doesn't know Dr. Tedros, who's essentially the Director General. So this is really a leadership position, really also the face, if you will, of the World Health Organization to the world. So kind of a position that requires both technical knowledge, capabilities, but also political capabilities in terms of kind of working with the different member states. There are also 6 regional committees, and overall, there are quite a lot of country offices where the WHO works. So as you can see, the WHO essentially has a very large universal network. In terms of its lawmaking powers, Chapter 5 of the Constitution essentially mentions these in 3 different provisions. One is Article 19, which talks about the authority of the WHO to adopt treaties. Another one is Article 21, which talks about its authority to adopt regulations in certain topics. And then also Article 23 talks about its authority to essentially make soft law, so to make recommendations. So some kind of normative documents that might have some normative guidance, but that are not legally binding. What is surprising, and for many it's been actually quite disappointing, is that the WHO, despite having these lawmaking powers, which were given it right upon its establishment, right, in 1946, has actually only adopted 3 binding treaties, which is very little if you think about it. So it has the nomenclature with regards to diseases and causes of death, which was adopted, which basically standardizes names on health matters. Then it has international health regulations, which were first established, concluded in 1951 and were adapted, amended several times until the last revision in 2005. And we'll be speaking mostly about that one soon when we talk about the pandemic, and the Framework Convention on Tobacco Control, which was adopted in 2003, which is a binding treaty. But if you think about it, in essence, there's a huge gap between the normative powers that the WHO has and the extent to which it's implemented them so far. And that's really been an issue of criticism, but also criticism, but also has been an outcome of political issues and so forth. As I mentioned before, they also have the right to issue recommendations. Article 23 talks about recommendations, and the WHO has used these powers. For example, the International Code of Marketing Breast Milk Substitutes in 1981, which was about limiting the use of breast milk substitutes, milk powder for babies instead of breast milk, was adopted as a recommendation. So was the Global Code of Practice on the International Recruitment of Health Personnel in 2010. So, and there are other examples as well. These are really just to show you that the WHO has also issued kind of these soft law recommendations. There's often kind of this question, what is more effective, the binding laws or the non-binding laws? And this is maybe something that we can get to in the question and answer session, because the fact that something isn't binding doesn't necessarily mean it doesn't have any impact. There were some studies that were looking at the extent to which these the breast milk substitute code was adopted within countries, and the uptake was actually pretty high. Here in the slide, you can see as of April 2020, a study found that 70% of WTO members had enacted legal measures with provisions to implement the code. In a moment, we'll see when we talk about the international health regulations, which are legally binding, that much less of it has been implemented. So I'm just kind of flagging this to say that legally binding doesn't necessarily always mean more effective or more implemented, and that there is also this value for non-binding instruments, which we need to think about when we design, future approaches to managing pandemics or any other health matter for that matter. So here too, WHO has global strategies. Again, this falls under non-binding rules. These are kind of strategies on diverse issues which are under its mandate, such as on non-communicable diseases, matters of alcohol, physical activity, and so forth. Again, it doesn't issue kind of binding rules, but kind of strategies that are supposed to guide member states, which then can either adopt this as binding or non-binding laws within their countries. Another point that I think is important to understand about the WHO is its funding. the WHO, there's a lot of expectations of the WHO. I mean, if you read the news, now it's become quite calm, but if you read it in the beginning, when COVID broke out, there was so much criticism in the news about, the WHO failing so much and so forth. But I think one thing that the general public is really missing is that the WHO is severely, severely underfunded. And that hampers its ability to deal with the many actually obligations that member states have put on it. So on the one hand, there's so many obligations and so many expectations of the WHO, but the money it has is really super limited. So the annual budget of the WHO is $5.5 billion US, which is not a lot considering health being such a major topic and so many countries around the world. It's actually a very, very meager budget. What makes it even worse, and this might surprise some of you, is that whereas in the past, 80% of funding came from member states and 20% was voluntary, over the years, this has swapped. And it's actually quite incredible to believe, but this is the reality, that 80% of funding these days to the WHO is voluntary. And only 20% is what they call assessed contributions or obligatory contributions. So, states and other actors decide whether they want to provide money to the WHO. So that's not a very great way to have any kind of, to manage your business, if you will, if so much of it is actually voluntary. You can't really be certain how much money you'll be receiving this or next year. And it's not only that it's voluntary, but actually most of this voluntary funding is earmarked, meaning that the contributors actually decide to what topic or issue the money is going to go. So it's not that they give it to the WHO and the WHO has its priority setting as to what matters deserve or of high priority should receive funding. The donor actually decides to what topic it should go to. So for instance, non-communicable diseases, so diseases that are not through infection like cancer, heart disease, diabetes, and so forth, are a major health threat. And in fact, the #1 cause of death in the world. But a lot of these voluntary fundings don't go to NCDs, so non-communicable diseases, but to very specific diseases or certain sectors and so forth. So you can see, so the point I'm trying to make here is it's not only voluntary, but it really goes to topics which then the donor can decide to what issues the money can go. And in that sense, the WHO is really very weak, having to rely on this kind of funding. And really, and this is something we'll talk about soon when we talk about COVID, but really one of the things that, have come up is like, we need to improve WHO funding, make it more stable, solid, reliable, bigger, and not have all this voluntary funding. Because this is really something that very much weakens the WHO. Here, this is kind of a funding snapshot. So you can see on the left, who provides most of the money to the World Health Organization. United States gives around 15% of the funding. And look who's number 2 after the United States. The Bill and Melinda Gates Foundation, a private foundation, is the second biggest donor to this international organization that is supposed to be protective of all of us. So you can see that this is almost an absurd situation where, in terms of funding. So that's really, again, in a nutshell, the whole funding issue and the WHO. As I said, so the WHO has been the main international health organization from the beginning. In the 1980s, the World Bank also became active. And then we have the rise of multi-stakeholder partnerships in the past 30 years. So you'll see a lot of those now if you look at global health. By the way, not only in global health, it's kind of a phenomenon that we see across the board in many areas in global governance, that we now see partnerships rather than intergovernmental organizations, which are composed only of member states. We see these partnerships where governments come together, developing countries, industry, civil society, international organizations, foundations, academia, they're all sitting together, trying to solve whatever problem it is. The background to this was really that over time, it really became, many people understood that it's almost impossible to solve kind of the problems of this time and age by just having one stakeholder, let's say just the government, at the table. We really need the input of different stakeholders for effective decisions to be made, and also for things to get properly implemented. So that's why we really see a kind of this rise in public-private partnerships. Here, this slide kind of tries to touch on some of the main issues that gave rise. One of it was really, as I said, that the complexity, and at the same time, this loss of confidence in the World Health Organization, where it just took ages, with so many member states, any kind of decision just takes ages to get anything done. So there was kind of a loss of interest in getting things done in the World Health Organization. Again, this complexity of topics, so much of knowledge, for instance, especially today, if you think about our technological world, or certainly also if you think about medicines, health matters, so much of the knowledge is within industry, government. This is only true of international organizations, but also governments. They don't have the resources, they don't have capacity to regulate effectively. They really are very much reliant on the resources, the knowledge, the expertise that is within these non-state actors, within industry actors. So there's really a need to come together and include them in partnerships. Of course, resources, money, as I mentioned, is a big problem. And so foundations such as the Bill and Melinda Gates Foundation started coming in, providing a lot of money, but then also, of course, wanting to be included in these partnerships. Globalization, of course, has made any topic even more complicated because now we have more countries involved in any possible matter. So we really see this rise in partnerships. Also today, if you look at the Sustainable Development Goals, you'll see that it's really part of the goals to try to solve sustainability problems through partnerships. So I'd say, partnerships is kind of the most governance model du jour, if you will, kind of this century. And we certainly see this also in global health, and you'll also see that in how we are dealing with COVID-19. So these are just several examples of kind of, I'd say, famous global health partnerships. The Global Fund to fight AIDS, tuberculosis, and malaria was set up in 2001, was really one of the first partnerships which brought together governments from developed and developing countries, the WHO, industry, civil society, foundations, really to tackle this problem of AIDS, tuberculosis, and malaria in developing countries. Another such kind of famous, very influential, big and influential, and have partnership is Gavi, whose goal is really to provide vaccines to children in developing countries. Again, was set up after providing vaccines to children in developing countries had always been within the WHO mission, but there was a sense at the time that it wasn't being very successful. And this partnership was set up and has been quite successful in providing vaccines to many, many children around the world. Again, set up as a partnership. More recently now, kovacs, I don't know if you've had an opportunity to hear about this initiative. I mean, if you're in the global health field, I'm sure you have, but it's also actually been mentioned even in the news. So kovacs is, again, an effort, a partnership, essentially, effort. I mean, the problem, of course, with the vaccines are that many of them have, with COVID-19 vaccines, are that many of them are being bought up by the high and by the rich countries. And kovacs is an effort to pool vaccines, get donations from developed countries, and procure and supply vaccines to developing countries. And that was again set up as a multi-stakeholder partnership with the WHO, Gavi, UNICEF, and other high-income countries, which were actually donating the money, and then developing countries which were supposed to receive the vaccines. This initiative was kind of, in the beginning, there was a lot of enthusiasm around it, of course, because it was really an effort to get vaccines fairly and equitably and rapidly to developing countries. As of now, it hasn't really succeeded. I think their goal was to get 20% of the population in developing countries vaccinated by the end of 2021, and they haven't succeeded, again, because many vaccines are being bought up by developed countries. So these are, just some of the existing problems we have around fair and equitable access to vaccines. But my main point here is really to say that, you see, even this new challenge of access to vaccines was set up as a partnership. And that's kind of the governance model that characterizes this time and age. Before I move on, Ankit, did you want to have questions in the middle, or should we keep it to the very end?
We can have the questions in the end, and I request the participants to share their questions, and we can take them up later on as well.
Okay, fantastic. So, okay, so this was really kind of a super fast introduction to global health governance and to the World Health Organization, which is its main kind of body, and some of the other partnerships which have become very prominent in the field. So following this background, what I wanted to do now is kind of look at some of the main challenges that COVID-19 has brought to global health law, and see what is being done about it and what could be done about it in the future, or how we should start thinking about how global health law should change in the future to deal with these kind of challenges. So the main issues really that I want to talk about is the international health regulations, and then the proposal for a pandemic treaty, and the whole matter of access to vaccines and medicines. So the international health regulations. So I mentioned them before. They're really one of the three treaties. They're called regulations, but they're essentially binding under the Constitution. Are essentially the main treaty, the only treaty that we have this day for really that deals with pandemics or other kind of outbreaks, in terms of its goal being to prevent and to set out a prevention and response to such events. So the first kind of regulations in this field really started many years ago in the 19th century in Europe. That was the International Sanitary Convention at the time. At the time, Europe was plagued by cholera, and the focus was on that. So it was mostly among European countries. And as years passed, each time there was kind of a different outbreak. So we see these conventions changing their focus from cholera to plague, and then smallpox and typhus and so forth. And for many years, even when the World Health Organization was set up, and then it was renamed to be International Sanitary Regulations, and then renamed in 1969 to be International Health Regulations, the focus for years was always on a set of infectious diseases. So cholera, plague, smallpox, yellow fever, and so forth. But the last version, which was revised in 2005, really opened it up, and it's no longer limited to any kind of disease. So in that sense, it kind of broadened the framework of the international health regulations. So in terms of structure, again, all member states are essentially bound by it, and it's legally binding upon them. So what I wanted to do now is kind of look at some of the main provisions in the international health regulations and kind of show you how they worked or worked not so well with COVID-19. Essentially, what the international health regulations try to do, I mean, kind of the main idea of the international health regulations is that they try to set up some kind of domestic system. So they have obligations on the member states in terms of how they are supposed to prepare and respond to a pandemic. And then the other part of the international health regulations kind of talks about the powers that the WHO has in that kind of situation. So let's start really with the purpose of the international health regulations. They say the purpose and scope of these regulations are to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks and which avoid unnecessary interference with international traffic and trade. So again, this is maybe something we could note already here, is that on the one hand, the international health regulations really want to prevent the spread of disease. That's kind of their main goal. But at the same time, they have a balancing aspect to them. They try to reach a situation where measures are adopted which prevent the spread of disease, but without overly undermining or unnecessarily undermining international traffic and trade. Okay, so this is in 2005. In the background, we have all kind of the international health, the trade revolution of the WTO, human rights. These are matters that are very important in the background. So there's really this notion that it's not an absolute value to prevent international spread of disease, but that we also need to do so without unnecessarily interfering with traffic and trade. That might explain also some of the actions of the Director General, which I'll mention in a moment. So let's look at state obligations. What are the main state obligations under the international health regulations? There are two main obligations, which are very relevant if we think about COVID-19. They're set out in Article 5 and in Article 13. So the first obligation is essentially that each member state must have national capacity to survey kind of what's going on within the country. So they need to have, as the provision says, the capacity to detect, assess, notify, and report events in accordance with these regulations and so forth. So that's a capacity they should have, which in a moment, which in Annex 1 tries to give out kind of a framework of what kind of core capacities a state should have. Essentially, but each state should have these core capacities in place. And the second obligation is that once something emerges, they need to have the capacity to respond promptly and effectively to public health risks and public health emergencies of international concerns. So if there were to be so first of all, they need to be able to survey whether at all there's some kind of outbreak. And second, they need to be able to respond very, very quickly. And for that, again, they need to have national core capacities in place, which are set out in Annex 1. This is Annex 1, which sets out the main capacities which each state should have. It's in a whole range of topics. They need to have certain laws in place. They need to have labs. They need to have human resources, and so forth. Hospital capacities to respond, to detect, coordination within the country. So there's a whole set of core capacities which each state should have in place. I can already tell you now that, in reality, that most of the countries have not had these, with COVID having broken out, most countries did not have these core capacities in place. So the fact that it's a legally binding document in itself was not sufficient for this to be implemented. There are different thoughts about why this hasn't worked out. Some of them are there's a lot of criticism on the lack of monitoring within the WHO. We'll talk about that in a moment. But also simply many countries don't have the capacity and they haven't really received support in building that capacity as well. So thinking about the future, we need to think about different tools in terms of how we can improve implementation, whether perhaps be it by carrot or stick, maybe more monitoring tools, or perhaps through carrots by more funding, technical capacity building support, and so forth. So I'm kind of just flagging that. But as of now, in terms of COVID-19, it's clear that most countries were kind of found to be without these core capacities in place. Another obligation that we have in the international health regulations is Article 6, which essentially says each state party shall notify the WHO by the most efficient means of communication available and within 24 hours of assessment of public health information of all events which may constitute a public health emergency of international concern. So here, of course, we all know there was a lot of criticism against China that they did not provide a notification within this period of 24 hours. This is Annex 2 of the international health regulations, which kind of are supposed to help states decide whether they need to give notification or not. So again, Article 6 apparently didn't work well in the case of COVID. Another issue is, do we declare a public health emergency of international concern? That power is essentially within the Director General. He or she decides on that. One of the criticisms in the past had been, before the most recent amendment, was that the WHO was really reliant on information coming from the state, so from the state in which that risk emerged. And of course, many states, they have an incentive actually not to notify. It's quite clear. If there is some potential danger from your country, people might start, most likely, you'll stop traveling to your country. It might impact your trade, might impact travel. So countries are actually hesitant about notifying, as we also saw in this case as well. So the international health regulations, when they were amended in 2005, sought to give the WHO more power to look for information independently and not to be so reliant on the member state from which the risk emerged. But this here too is actually a very weak provision, because as you can see, Article 9 says that the WHO may take into account reports from sources other than notifications or consultations from that state party. But before taking any action based on such reports, the WHO shall consult and attempt to obtain verification from the state party in whose territory the event is allegedly occurring. So essentially, it really still gives power to the member state in which the event is occurring. And in that sense, it keeps the WHO very weak. And I flag this because really one of the main criticisms that have come up and in reform discussions is, how do we strengthen the WHO? How do we give the WHO more powers going forward? And then the issue is declaring a public health emergency of international concern. So the Director General then, based on all the information, he or she can then declare that there is a public health emergency of international concern. And after that, once there is that, that's like kind of alarm bell for all member states, okay, get your act together. And now this is time to act. And the Director General can also issue temporary recommendations. Again, here, the criticism has been that it took too long to declare a public health emergency of international concern. This has also given rise to ideas about how the system could be improved, perhaps to have kind of like a traffic light system, because now it's either white or black. It's either no public health emergency of international concern or there is one. And of course, given the considerations that I mentioned before of traffic and trade, WHO is hesitant about issuing such a declaration. So one of the thoughts is, maybe we should have kind of more like a traffic light system going forward. Again, I just want to flag this here as one of the problems with international health regulations. So as I mentioned, after that, Director General can issue temporary recommendations, which again, they're not binding on the state. So for instance, the Director General at the time recommended not to halt travel. And as you all recall, most countries, if not all, didn't abide by that. Again, it's legal under the Constitution, under the international health regulations, but it does show the weakness of the WHO in terms of issuing instructions to member states. This is another point, the issue of monitoring mechanisms, which I mentioned before. So there are all these obligations on member states in terms of surveillance, in terms of having a quick response in place. And the main kind of overview mechanism of that under the international health regulations are monitoring mechanisms. But these are very, very weak mechanisms. They're for the most based on self-reporting. So states kind of undertake their own reviews, whether they have their core capacities in place or not. A couple of years ago, they also introduced kind of joint external evaluations, meaning a state can invite external experts to work together with their experts and assess their implementation and compliance. But again, this is a very voluntary model. So overall, the monitoring mechanisms under the international health regulations are very weak. And that's also been one of the criticisms coming out of COVID-19. A last point here, also, again, there was all this debate about, what was the origin of COVID-19? Where did it come from? From a wildlife market, from a lab, we really didn't know where it came from. And the WHO was unable to enter China because, again, the WHO doesn't have such enforcement powers. It can't enter. The entry into China to undertake such an investigation is entirely dependent on China's approval that the WHO come in. So there is absolutely no binding inspection panels, which the WHO has, which again has given rise to criticism. It's not a very easy topic because, were the WHO to have more powers, that means the state would have to give up some of its sovereignty. And for many countries, that's not something they give up very easily. So again, I'm kind of flagging this as the WHO is very weak, essentially, in its enforcement, in its inspection powers, in its monitoring powers. It's quite clear that has come out from COVID. A lot of the debate, as you will see, is how to strengthen the WHO, but it's not going to be easy because any kind of strengthening of the WHO will require states to give up some of their powers, sovereignty, and that's not an easy task. So to summarize, kind of the main challenges coming out of the international health regulations is, as I mentioned, domestic capacity, core capacities very much missing in many countries. Domestic notification hasn't worked well. The public health emergency of international concern declaration was quite slow. We have a very weak monitoring and compliance mechanisms. The WHO doesn't have any enforcement powers. So overall, the international health regulations have been quite unsuccessful, unfortunately, in managing COVID-19. And on top of that, there are many, many matters that are not covered at all in the international health regulations, which I'll talk about in a moment when we talk about reforms. But maybe one thing which is quite evident is the international health regulations, for example, only kick in once there has been an outbreak, right? Once there's an outbreak, then everyone starts moving, need to notify, prevent, and so forth. But actually, we know now that many of these diseases, they are zoonotic spillovers. They come from other animals. So there's actually a lot of work to be done in the prevention side, but there aren't any international legal frameworks trying to deal with actually preventing the prevention of these outbreaks. So that's also one of the issues which are missing, and many more, which has led to much discussions now among member states, within the WHO, amongst civil society, among global health scholars. What do we do? I mean, this is obviously an immense tragedy, and we don't want it to happen again. How can we change in the future global health law to better deal with these kind of pandemics? So before I move on and talk about the pandemic treaty proposal, I don't know, how am I in terms of time, Anki?
Well, 45 is up, but please take your time. We're in no rush, and it's an engaging presentation, so it's completely fine. Please take your time. There's no rush.
Okay, fine. Okay, cool. So let's. So before we talk about the pandemic treaty proposal, another issue that has given us some trouble with COVID-19, and more generally also, of course, on the whole issue of access to vaccines, has been the TRIPS agreement. Essentially, the TRIPS agreement, which is part of the WTO, World Trade Organization agreements, introduced in 1995, what it did, it essentially introduced an obligation on all member states, on all World Trade Organization member states to, they're obliged to protect patents. And these patents are inclusive of pharmaceutical products as well. So essentially, if there's a pharmaceutical product that has a patent, all member states are obliged to protect that patent for a period of at least 20 years. That's under the WTO, under the TRIPS agreement. Now, this, of course, has given there have been so many debates, especially after the AIDS pandemic, about how this actually undermines access to medicines, because, of course, patented medicines are expensive. And as a result of that, many developing countries do not have access to new medicines that are under patent. So there's this very strong tension between generic medicines, so essentially medicines that copy these patented medicines and are cheaper, and this continued protection of patented medicines, and a lot of demands by developing countries, but also civil society and those that are giving voice to these more vulnerable voices, saying we need to find a way to protect. Okay, we'll accept this patent system, but we need to make sure that it doesn't undermine access to medicines. So to that end, the TRIPS agreement kind of recognizes that and introduces all kinds of flexibilities that are supposed to, on the one hand, give patent protection to goods. TRIPS applies to all goods essentially, but of course, in the context of our discussion, we're talking now about pharmaceutical goods. So it does recognize there are different provisions that talk about flexibilities that are supposed to balance between this patent protection and the need to protect public health. And there are all kinds of provisions in the agreement. For example, one of the flexibilities often discussed is a matter of compulsory licenses. So this notion that if there's a public health need within the country can actually issue a compulsory license, meaning that the patent holder will receive money for that medicine, but is under an obligation to actually provide a license, which it wouldn't otherwise do. And again, here the idea is, how can a country that has some kind of public health emergency provide medicines to its population? And that's what Article 31 on compulsory licenses tries to achieve, really enabling countries to issue these compulsory licenses. This right of states to issue compulsory licenses was then further strengthened with the Doha Declaration on the TRIPS agreement in public health in 2001, kind of again reinforcing the right of states to use these TRIPS flexibilities in order to promote their public health interest. One of the problems under the TRIPS agreement, though, is that while on its face it sounds like a very good solution. So if you have a public health interest and or some kind of national emergency, and you need to have access to medicines in the country, then you can issue a compulsory license and thereby actually provide generic medicines to your population. One of the problems is that the TRIPS agreement essentially limits that use to your domestic population, meaning that essentially only countries that have manufacturing capacity can use this flexibility. So you can't be, for instance, in a situation where you have a country like India that has manufacturing capacity and then sell those drugs to a small Caribbean country, say, that doesn't have that manufacturing capacity. That wouldn't be in line with the TRIPS agreement. So it's really, in the end, very much limited. Only countries that really have this manufacturing capacity for themselves can make use of this kind of flexibility. The Doha Declaration at the time said that they would try to find a solution around that, but as of yet, nothing has been achieved. So the point is really here that even though we have these TRIPS flexibilities, they're quite hard to implement in practice, for that being one of the reasons, this issue of lacking manufacturing capacity in different countries. So one of the issues that now came up in the context of COVID 19 again, because as you know, what happened is that most of the vaccines are essentially had been developed and produced by the pharmaceutical countries, most of which are in the West, and there are patents on these vaccines. How do we make sure that these vaccines reach developing countries? So there had been a proposal by India and South Africa in the WTO to waive the TRIPS altogether. So any developing country anywhere in the world could actually manufacture these vaccines without being concerned about being sued under WTO laws. As of now, there's quite a deadlock in these discussions. But this also is kind of an issue which really shows you how IP matters are also an issue that going forward need to be resolved. I don't know that there's any solution yet. There's this deadlock at the WTO, but this is certainly an issue that we'll need in terms of thinking about the future of global health law. How do we better deal with these IP issues when we have these kind of emergency situations, these pandemics? Okay, so let me then move on to the pandemic treaty proposal. So again, given all of these problems, especially with international health regulations and kind of this realization that so many topics aren't properly dealt with within global health law, there have been calls to develop a new pandemic treaty. And there was a special session this past November at the World Health Assembly. And they also set up now this shifted, a negotiating body, which will start drafting and negotiating this year. So what I want to do is kind of look at some of the main proposals that have been raised by member states. Again, remember, this is a very, very initial stage. But I think if we look at some of the proposals that have been raised, again, we'll get a better understanding of matters that haven't worked well in current global health law and how some states, what they have in mind in terms of the future of global health law, especially as it pertains to managing pandemics. So this nice image is taken from a report which was written by the Global Health Center at the Graduate Institute in Geneva. And what they did was they really did a very nice exercise. They looked at all of the proposals that were submitted at that session in November and try to categorize the different areas of reforms which are being proposed. So I'll try to go and touch shortly on these different areas of reforms and see where the main discussions are. So in terms of treaties, so one issue is treaty design. What are we going to do with this new treaty? Here there are different debates. Some countries are saying we just need to strengthen the international health regulations. Everything's already in the international health regulations. The problem is, as I just told you, is that it hadn't been properly implemented. Let's just strengthen its implementation. We don't really need a new kind of instrument. A new instrument will just, make things more complicated. Others are saying we need a new instrument, but we really need to make sure that it works well, that it's complementary with international health regulations. Others are saying we need a framework convention, meaning it needs to be a very vague and general convention, can't be too detailed. And I have to say, I tend to agree with that because so much in terms of public health at the domestic level is so dependent on very local practices that it would be very difficult to create some kind of treaty that is very detailed at the international level. So we kind of need something relatively vague, which can then be implemented through protocols or different kind of guidelines. Others have really stressed the need to have some kind of guiding principles, bring in more kind of values, cross-cutting values, matters such as solidarity or transparency, and so forth, kind of guiding principles that will guide us in the way we implement this treaty going forward. And another point is, especially the European Union is saying, we don't need to be bound again. And this links to what I said before about the hard law and soft law. we don't need to be bound. Like, we can work with different tools. We can work with hard law tools. We can work with soft law tools. Let's not, bind ourselves, and let's just work with whatever will be most effective. In terms of governance, there are also calls to set up a new kind of independent body. Here, really, the question is, will it be in the WHO? Will it be outside of the WHO? These things are not quite clear. Like, do we need a new kind of international organization, or do we need something that's going to be subject to the WHO? These are open questions. I think everyone's quite clear that we need to strengthen the financing of the WHO Secretariat. That almost goes without saying. Strengthening WHO authority. So this links to what I said before about how weak the WHO actually is under the international health regulations. There are calls here to really increase the power the WHO has in terms of monitoring, and not only have self-reporting, have external oversight, obligatory oversight, inspection panel powers, maybe also have kind of compliance enforcement powers. As I mentioned before, these aren't easy topics, because it's all about giving power to the WHO, and in that sense, taking away power from states, which is not all states will look at this equally. Another thing, a very strong matter, of course, is sustainable financing, which, as I mentioned before, is really key to any kind of reform. So we can dream about any kind of reform we want, but if it won't be attached with proper financing, nothing is going to work. And we need this financing both for the organization, but also for building capacity within member states, as I mentioned before. In terms of preparedness, again, there's consensus that we really need to build up health systems within the countries, build up their core capacities, that we need a global alert system. Right now, it's very much dependent on the state where the event occurs. But as I mentioned, the incentives might not always be aligned with the global incentives. So maybe we need some kind of global system that isn't dependent on the state, some kind of like a fire alarm system. Another matter is, as I mentioned before, do we need to have like a traffic light system when we think about declaring a public health emergency of international concern? And other more general things, of course, is that we just need more cooperation between the different international organizations, and also between states. So if we think about trade and or intellectual property and the World Health Organization, all of these need to work together, and not really keep within the silo of their own organization. And of course, always we need more cooperation and sharing between member states. Another kind of really new thing, and conceptually, is to introduce the One Health approach and zoonotic risk into the treaty. So One Health approach, again, in a nutshell, is really this idea. It's been around for many years, but it hasn't been adopted into any legal document per se, and not into any international legal document, I want to say. The One Health approach basically says we can't keep humans healthy without realizing that it's a triangle. Human health is linked to animal health, is linked to environmental health, and the one impacts the other. Climate change obviously has a change, or pollution has an impact on human health. Animals have an impact of health on human health. As I mentioned before, all of these zoonotic diseases, these are spillovers from animals. So if we really want to prevent pandemics, we need to start thinking in a One Health approach. And the calls here are really to introduce this concept as a cross-cutting concept within any kind of treaty. And linked to that, of course, really give much more attention to the matter of zoonosis risk and deep prevention. We kind of know where most zoonosis risk exists in the world. They're all kind of mapping exercises. So how do we increase surveillance in those areas where we think that there could be more spillover of diseases? And also the matter of biosecurity. I mean, as we know, there are risks of leaks from labs, and that also there isn't actually any international legal document looking at that. So irrespective of what really happened in COVID, this is certainly something we need to be thinking about going forward. Again, these are governance issues: compliance, transparency, and accountability. I I think these are things I've mentioned before as well. We really need to improve transparency between countries, between organizations, disclosure of what's happening. We need more accountability mechanisms to monitor and to enforce and to make sure that everything gets implemented and enforced. So we kind of need more and stronger governance mechanisms. Which brings me to the last point before we end. And that is really the whole issue of equity access to medicines. We talked about the international health regulations. There is no word there about access to medicines or vaccines. So all of this is not regulated anywhere. That's why what we got now with COVID was kind of like, the law of the jungle. Like the countries that had the most money essentially bought up the vaccines. That's what happened. So going forward, we don't want that. We want to make sure that we have more equitable and fair and rapid access to all people around the world. So that we need to start thinking about how we create a global health law and governance infrastructure that can support that. So first of all, of course, we need to have equity as a principle, as a guiding principle, but there are many other practical things we need to think about. One is scientific sharing, pathogen sharing. We have these pathogens around the world in different countries. Countries need to be able to share these very fast because, of course, any kind of medicine or vaccine development by industry or governments is dependent on getting access to that kind of data. So how do we improve? How do we streamline that? That countries, especially developing countries, provide pathogens or genetic data on pathogens in their area, and against that, how do we then do we create new kind of infrastructures where there's kind of a win-win situation where some countries provide their data on the pathogens and perhaps in return, if you will, get access to vaccines once they're developed by the industry and by other countries. So we need to really think, how do we create a system where there is fast and equitable sharing of this scientific information while also creating vaccines fastly and distributing them fairly and equitably. So these are kind of the main issues that are being discussed. As you can tell, many complicated topics. It's going to be quite hard to reach an agreement. So we're just going to have to follow in the months and years ahead and see where this takes us. I assume that also some of these issues will be managed at a regional level. Some countries, I believe, won't wait until things get settled at the WHO because that might take years. So that's also something to follow, see what's happening, especially here in Asia, I would say. What kind of developments are going to be taking place around that, such as on what I mentioned on scientific sharing and access to medicines. I could imagine that this is something that perhaps could be developed more rapidly within a regional area. So just, I guess, final words. I mean, as you can see, COVID-19 has really challenged global health infrastructure. And now there are discussions about how to reform any kind of reform in the end. I mean, we can come up as lawyers with all kinds of legal constructs, but in the end, it really, again, because we're talking about the international level, it'll very much depend on political willingness. And as you know, we have different states with different, very strong opinions about what is right and how they'd like to see the world manage funds. It'll take a lot of time. Industry is a major factor here. How will we make sure that their interests are aligned, and so forth. So I think we're in interesting times. I'll close with that. Sorry if I went over time, and I very much look forward to your questions.
No, it was a riveting presentation and quite wonderfully done. Thank you so much for sharing your thoughts. It does give one quite a lot of food for thought, and we do have a question as well from Gabriella. I'm just going to stop the screen share so that one can see.
Oh, I'll stop it here.
Gabriella, please kindly introduce yourself and share your question, please.
Hello, good morning. My name is Gabriela Porto. I'm from the Getúlio Vargas Foundation in Brazil, and we currently here in the Jamonet Center of Excellence have a research on the WHO normative production. And we met you in the article on the capture of the WHO. And I was wondering if you could elaborate a little bit more on the WHO normative production, and if there are elements that could help us identify if a document it's a normative one or not. So beyond the differences of hard law and soft law, if there are elements of bindingness or not, and in this context, the outcome of the participation of experts. So experts are not necessarily from lawmakers, but this intersection interests us very much. Thank you and congratulations for the presentation. I really enjoyed it, and thank you for the Jinda University for the organization. Thank you.
So, Doctor, would you like to take all the questions together? There's another hand raised and there's one in the chat box also. So you can club the three and then take them together.
Sure.
All right. Ishita, would you like to proceed with yours, please?
Hi, it was an amazing presentation. There was so much to learn. So I have two questions actually, and I understand that WHO does not have the enforcing powers to force a country to share data. However, aren't there any punitive measures which WHO may adopt in case a country does not cooperate in terms of sharing information or allowing WHO to conduct research, especially with respect to COVID-19, what happened? And my second question is that if we are to imagine a point of time in future where countries are willing to let go of some of their sovereignty in the spirit of good governance, can we be assured that WHO would not be influenced by a particular country which is powerful? And consequently, is that the reason why countries and jurisdictions are doubtful of international organizations?
And there's a third question in the chat box as well. This is by Akshay Dhruva. And he's really asking you about the equity principle of the organization, and also that should there be a new institution which should be set up by smaller countries or perhaps third world countries, which would perhaps also counterbalance China's role as a contributor to the WHO. And the third question, and I think that this ties all these questions which he's posing, is will funding increase the efficiency of the organization, and how much of a injection of monetary assistance will allow the WHO to function as an effective international organization. And if I could just add to that, perhaps you could also reflect on the sudden attention that the WHO found itself on. Perhaps we're being too critical of the organization, but then that's the whole point of an organization. And can one really take it to take it at face value that the organization is not being able to do this, and also speak about the funders and Bill Gates speaking in a TED talk and warning us off a pandemic which was coming. And where did really the pandemic preparedness plans of especially the United States stand? Because they knew something like this would happen, but they were not, or at least were not able to react to it in a sufficient manner. Whereas small states were able to deal with it comparatively better, like a New Zealand or a Taiwan or a South Korea, which also has such plans which are specifically related to Tsar viruses. So there's a few questions. I've gone on a bit of a run here, but you can address them as per your order which you prefer.
Okay, great. So many great questions. So Gabriela, just to make sure I got this right. So you're looking at all kinds of norms coming out of the WHO, and you're essentially asking yourself, and as this is part of your research, if I understand, which ones are binding and which ones are not binding. And within that, how should I refer to expert decisions or resolution, expert committees and stuff like that? Is that correct? Did I understand correctly your question?
I think her screen is frozen, but I think that's quite accurate.
Yeah. Okay. So again, I think under the WHO, in terms of what's binding under the WHO.
Yes.
Yeah.
Wait,
So if
I'm sorry.
So if that's so binding is only what has been concluded under Article 19 or Article 21, and if it hasn't been mentioned as such, then it doesn't fall within those binding provisions, which means that essentially almost all of the rest is non-binding. Certainly, these expert committees resolutions are not binding. They're normative documents. But as I said before, the fact that they're not binding doesn't necessarily mean they're not important. That's not at all the case, certainly not in an organization like the WHO, which has what we could call epistemic legitimacy. So many countries and many experts look to it for its expert knowledge. And so, if an expert committee, for instance, issues a resolution, that can have very significant impact because they give a lot of weight to their position, irrespective if it's legally binding or not. So I'm not entirely sure for what you're doing this research. I'll just say that overall, I think what we see is that the legally binding or non-binding nature of many of the instruments doesn't necessarily say much about how impactful it is. So if you want to derive importance, that's not necessarily always the way to go. Yeah. I don't know if that answers your question, if you had some follow-up on that. She's gone. Okay. Can you? Good. Okay. So the second question was the WHO, and are there any punitive measures when member states do not cooperate? No, the WHO does not have any enforcement powers against its member states, essentially. It doesn't have any legal powers in that sense. They can't make them implement their core capacities. They can't make them notify. They can't make them let them into the country. There are no punitive, certainly, yeah, there are no punitive measures. So in that sense, the WHO is really weak. It's a state will cooperate if it's in their interest, if it's in their self-interest, political interest, reputational interest. There might be a whole bunch of reasons why a state might decide to comply with a request by the WHO, but it's not a legal one for most of these issues. Okay, so if they come in and say we want to inspect the country, there's no legal obligation or legal sanction if they do not agree, but a country might for other reasons, as I said, like reputation or standing, diplomacy, all kinds of other non-legal reasons decide to cooperate. But legally speaking, the WHO is weak. Then the second question was, I'm not entirely sure because I just took I scribbled it here, so I'm not entirely sure.
Can you repeat it, Ishita, if that's possible?
Yeah, I'm sorry. It was something about.
That's completely fine.
Yeah, sure. So I wanted to ask: can the WHO function as an independent authority, or do these states have a reason to protect their sovereignty against it?
Mm. Yeah, I mean, that's that's exactly what states are afraid of. I mean, giving away power to an international organization is something that many states do not want to give. And I think that will continue being the main problem. We see it in very few organizations, actually, international organizations. Like, for instance, in the WTO, we see a dispute settlement mechanism, which is between states, by the way. It's not the international organization against them, but which gives this kind of enforcement powers. But in general, in most international organizations, states are very, very reluctant about giving away the power. In effect, many international organizations, if you look at it, are really mostly about coordinating relationships between states, exchanging information. That's really the core of their work. And states are afraid to give them enforcement powers. The one exception would be like the Security Council, but that's really a rare example. And that happened after World War II, where, there was a political state of mind where countries were willing to give that kind of power away. In today's day and age, I don't see it happening so fast, I have to say. Then there was the question of the equity principle. Should a new institution be set up by smaller countries? Well, the issue was with setting up to counterbalance China. I guess the issue is, there's always a value to an institution of like-minded states. I'm thinking, for instance, Singapore, and there's ASEAN, and they have common interests. I think, in principle, I think there's always, there could be an interest for setting up institutions, local, regional institutions, because of the like-mindedness and shared interests by certain countries, also easier to reach decisions. So there's a lot of logic to that. Of course, any kind of institution you set up that takes up resources, time, might contradict or conflict with the work of another international organization. I don't think there's a right or wrong answer here. I think it really depends on the circumstances, and if there's any benefit in setting up a more regional kind of body that can deal with more, topics which are of interest to a certain region over an international body. In terms of funding, I can't say. I'm not a finance person, unfortunately. I can't say how much money they would need, but it's quite clear from any professional that you read about this that, they would need much, much more. I think they keep on saying that, like, the annual budget of the WHO is like the budget of a large university hospital in the United States. So that just gives you kind of a proportion of how little it is, given that there's so many health problems in the world. I mean, COVID is really just one. I want to remind you all, we have non-communicable diseases, we have accidents, mental health, other communicable diseases. People are getting older, many countries. So I would want to believe that if there would be more funding and good management and good accountability, then yes, they could do more stuff. I would want to believe that's the case. Then there was another question about the funders. I'm so sorry, I scribbled it. That there is an issue of that we're too critical of the organization. Do you recall what that question was?
That was mine. So perhaps you're being extra critical of the organization and its structure and its preparedness vis-a-vis the modus operandi or the mechanisms available to it and perhaps it's also because of the states' inability to uh, be able to be quite straightforward with it. Test, trace, test, treat. I mean, it's not rocket science, but as we see, these test preparedness plans of states have been quite ineffective, at least in the beginning, and now perhaps states have caught up, at least in terms of being able to provide vaccine and also trace and also test. So it's really a joint effort, and I think South Africa should be complimented for being so open about it and forthcoming about it, and protecting large swaths of Africans, also humanity writ large.
Yeah, I could not agree more. Of course, it was very much the state's responsibility. I think what we saw in the beginning of the pandemic was kind of a political maneuvering. I mean, many, especially Western states, were totally caught by surprise. It's true that they had some kind of national pandemic preparedness, but they hadn't ever really experienced anything like that. So they were totally unprepared. And even when things kind of the declaration and warnings were coming out of the WHO, they were not moving. I know it, many European countries weren't really doing anything, also the United States. So I think there was a big problem of states not being ready, not acting fast enough. Part of the blame on the WHO was, at the time, you recall the political environment we were living in at the time. So there was a lot of kind of political maneuvering, I think, pointing the finger at the WHO. I think we're beyond that point. I don't think we hear these kind of discussions anymore, because the politics have changed, and the sense is that we're more towards working on cooperation. But I think there's no question that the states had as much responsibility for not implementing and not responding quickly. I mean, being in Singapore, the response was very, very quick. I think maybe in Asian countries, because of the SARS pandemic in 2003, they kind of immediately, first of all, they had plans. So the countries themselves had plans in place, which other, Western countries didn't have. And I think also the population, I mean, they immediately got it. They're like, okay, we need to wear masks. Like, we get it. We need to be in small groups. This wasn't the first drill. I think in the West, this was like, so even at a cultural, social level, to get, not only politically, get people to realize what was happening had very much to do with not having this past experience, which Asian countries had with the first SARS. So yeah. States definitely had a role to play as well, no question.
I think with Omicron finally dying out, it's good for humanity writ large, for us to be able to connect physically. But as we do connect virtually, I would like to thank you, Professor, and also our audience members for joining us for this discussion. We're so thankful to everyone for taking out time, and we look forward to welcoming everyone else for our future discussions on similar topics of pressing need and requirement. Thank you everyone for joining this discussion. Professor, any final words, and then we can close.
Just thank you very much for inviting me. It's really great to collaborate with you and to talk about this issue. And if there are other people in global health that are interested and want to follow up, you have my email, and I'd be happy to answer any follow-up questions or to continue the discussion.
Thank you so much. Thank you, everyone else. Good evening.
Bye-bye. Thanks.